Welcome back. Now I'm going to introduce my next, my colleague for the next session, Dr. John Apsolidis. He is a consultant hematologist in the Department of Adult Hematology and Stem Cell Transplant at King Fahd Specialist Hospital in Dammam. Welcome, Dr. John. The floor is yours.
Thank you. I would like to thank the scientific committee for the honor to moderate this evening's session of an outstanding meeting. We have a panel of distinguished speakers that will address very interesting topics. The first part will include presentations by Dr. Francine Foss and Drs. Jane Armitage, followed by two satellite presentations chaired by Dr. Faraz Al-Farih. A question and answer session will be held after the first satellite presentation. I encourage the audience to submit their questions through the Ask Question button under their screen. So without any delay, I would like to introduce our first speaker, Dr. Francine Foss, who is Professor of Medicine in the section of Medical Oncology at the Yale Cancer Center. Dr. Foss is an international recognized clinician and clinical researcher with expertise in adult lymphomas and in allogeneic stem cell transplantation. Dr. Foss has pioneered several novel therapies for T-cell lymphomas and has led significant national clinical studies in the USA. The title of the presentation is, "What is the future of immunotherapies for T-cell lymphomas?" So Dr. Foss, thank you for being with us. The podium is yours.
Hello, I'm Dr. Francine Foss from the Yale Cancer Center in New Haven, Connecticut, and I'll be talking to you about the future of immunotherapy in T-cell lymphomas. As you know, there are a number of different subtypes of T-cell lymphoma, and this is the WHO classification showing you that T-cell lymphomas are divided into leukemic diseases such as T-cell PLL and LGL and adult T-cell leukemia. The nodal diseases more common, including peripheral T-cell lymphoma, angioimmunoblastic, and the anaplastic large cell lymphomas. Then we have the extranodal group, which includes NK T-cell lymphoma, enteropathy, hepatosplenic T-cell lymphomas, and paniculitic. We also have breast implant-associated T-cell lymphoma that's a new entity. And in the cutaneous group, we have diseases such as mycosis fungoides and the Sézary syndrome, and the CD30 positive anaplastic large cell lymphomas, among others. PTCL generally has an inferior outcome compared to B-cell lymphomas. You can see the distribution of subtypes shown here. And again, the nodal PTCL, such as PTCL-NOS, angioimmunoblastic, and anaplastic large cell, are the most common subtypes. With the exception of ALK-positive anaplastic large cell lymphoma, outcomes are poor for all of the other subtypes, with a median survival of 2 to 3 years for many of these. So upfront therapy for T-cell lymphoma is generally a CHOP type regimen. You can see that there have been some variations on CHOP, such as combining it with pralatrexate or combining it with a gemcitabine-based regimen. And you can see the outcomes with median progression-free survivals here are poor, less than 1 year, compared to what we expect with B-cell lymphoma. In addition, with T-cell lymphoma, we like to attain a complete remission up front and then take a patient to an autologous transplant. The data shown here are the data from the Nordic study, which is a prospective study where patients got a CHOAP regimen. And then if they had a complete remission, they went to an autologous stem cell transplant. Even under the best of circumstances, you can see that the median progression-free survival and overall survival is that about half of these patients are going to fail this therapy at 2 to 3 years. And again, this points out to the fact that even when we use optimal therapy up front and get a complete remission, there's an unmet medical need for this disease. So we need to start thinking about novel therapies and novel ways of approaching these patients. Thus the need to look at immunotherapy as a possibility. The FDA approved agents in the United States are pralatrexate, which is a folate antagonist, 2 HDAC inhibitors, romidepsin and belinostat, and then chitamide is approved in China. And then brentuximab vedotin, which is a CD30 targeted toxin. You can see the overall response rates are not exceptional, with the exception of brentuximab, and progression-free survival is short for these new agents. So the groundbreaking study in the last year or two was ECHELON-2, which combined brentuximab vedotin targeting CD30 with CHOP in patients with untreated CD30 positive PTCL. So for the purposes of this study, patients who had immunohistochemical expression in greater than 10% of their cells were eligible, and all histologic subtypes were eligible. The endpoint was progression-free survival, and then overall survival as a secondary endpoint. This was a randomized study with brentuximab combined with adriamycin, Cytoxan, and prednisone versus CHOP. And the outcome for this study was a little bit surprising in that there was clearly an improvement in progression-free survival for the brentuximab arm at 57 versus 44% at 3 years. You can see the p-value was 0.11. But also, interestingly, there was a survival benefit as well with a p-value of 0.2 for the brentuximab plus CHP arm. Now, if you look at the different stratification factors, you can see that all patients benefited, with the exception of angioimmunoblastic, which showed a slight preference for the CHOP versus the brentuximab. And again, the numbers are very small here, so it's difficult to conclude anything. Clearly, the patients with anaplastic large cell lymphoma with a high expression of CD30 did exceptionally well in this study. So what can we conclude from this data? Clearly, there's a benefit in overall survival with the brentuximab arm. However, most of the patients, about 66% of them, were anaplastic large cell lymphoma. So the real question is, will this data hold for other subtypes? The study was not powered to look at those other subtypes. And what is the role of consolidation transplant? Now that we have excellent upfront data, at least in anaplastic large cell lymphoma, is there a subset of patients that should not go to autologous transplant? I think that still remains an open question. In addition, we don't have data on the CHOAP plus brentuximab regimen. Many of us are incorporating etoposide upfront, and the studies are now ongoing looking at the combination of etoposide regimen with brentuximab. So if we use brentuximab CHP, do we even need etoposide? Is that going to be just as good as CHOAP, for instance? So again, these are subjects of ongoing trials. Suffice it to say, I think that there's still a question with respect to the benefit of brentuximab upfront in the other subtypes, and what is the optimal frontline regimen for many of our patients. So another question has been, should we incorporate other drugs upfront? And I'm just showing you this slide because there's been a lot of work looking at epigenetic mutations across the different subtypes of aggressive T-cell lymphoma. And angioimmunoblastic T-cell lymphoma is a subtype that has many of these mutations, including TET2 and DNMT3 and IDH2, in addition to the RHO-A mutation that occurs in about 70% of AITL patients. So it would make sense that you could approach these patients with epigenetic therapy. And in fact, there has been a study looking at 5-azacitidine. Again, this is a small study with AITL patients, but showing very good overall response and response duration, with a response rate of 75% in a small cohort of patients. So this was exciting data, and a subsequent study combined azacitidine with romidepsin in PTCL. And this was a phase 1 study looking at not only T-cell, but other histologies as well. Within the T-cell lymphoma group, the overall response rate was 73%. And you can see the doses of azacitidine given days 1 through 14, and romidepsin given on day 8 and 15 on subsequent cycles. And so this actually is a combination that's being taken forward in a larger study. So then if we start talking about immunotherapies and how we would approach patients with aggressive T-cell lymphoma, we'll talk a little bit about antibody-based therapies, checkpoint therapies, and CAR-T. So touching on antibody therapies, this is mogamulizumab, which is a humanized monoclonal antibody that targets CCR4 And this drug is approved in cutaneous T-cell lymphoma in the United States and for HTLV-associated AITL in Japan. Again, this is a naked antibody that's not conjugated. And it turns out that CCR4 is expressed across a wide range of malignant T-cell lymphomas. And this data shows you patients with mycosis fungoides at different stages that express CCR4. And you can see that as the disease becomes more aggressive, from patch to plaque to tumor, you can see the expression of CCR4 increases. So there was a trial, a phase 1/2 trial looking at mogamulizumab in CTCL. The drug was given weekly for 4 weeks and then every other week. You can see that in this small trial with mycosis fungoides and Sézary syndrome, there were patients with complete responses. And you can see an example of a nodal response, as well as patients with circulating malignant cells that disappeared very quickly on this trial. And so based on these results, a large randomized trial called the Maverick trial randomized patients between mogamulizumab and oral vorinostat. And there was a crossover for patients if they progressed on the vorinostat arm. There were 372 patients randomized, and there was no requirement for CCR4 expression, although that data was obtained. And again, all patients were eligible for the study with progression-free survival as the endpoint. You can see on the right-hand side of the slide here that patients with circulating cells with Sézary syndrome did better than patients with MF. Overall response rate was 28%, but it was 37% in those patients with circulating cells. And you can see stage 4 patients also had a very good response rate of 36%. The duration of response median was 14 months. And you can see that it was higher in the Sézary patients. So in this clinical trial, the progression-free survival endpoint was met, favoring mogamulizumab, as you can see. And if you look at the waterfall plot, you can see that most of the patients who received mogamulizumab did have some reduction in their overall skin score, even if they didn't attain a documented partial or complete response. Again, the compartment response was different, with blood response being higher. And this is actually very similar to what we see with CAMPATH as well. With respect to adverse events, there were infusion reactions and some drug eruption, which was difficult to discern from the underlying disease, as you can imagine. And sometimes we had to give steroids to get over the drug eruption and then move on with the therapy. Another interesting antibody not yet FDA approved is IPH4102, which targets the KIR3DL2 receptor. It turns out that KIR3DL2 is expressed in mycosis fungoides and Sézary syndrome, as you can see on these immunohistochemistry slides. In addition, you can see on the bottom that the expression is higher in transformed or MF with large cell transformation and Sézary syndrome than it is in patients with patch plaque stage disease. And in an early trial with 44 patients with advanced CTCL, many of whom were Sézary patients and heavily pretreated, you can see that many of these patients had very good clinical responses. And based on this data now, the FDA has fast-tracked this drug for a larger study for approval in patients with CTCL. So that's going to be very exciting to see those results. I'll talk about checkpoint inhibitors now because that's obviously an area of great interest for us in other diseases, solid tumors, Hodgkin's, myeloma, etc. But it turns out that in PTCL, the data with checkpoint inhibitors is not yet where it is in other diseases. So in small studies with pembrolizumab and nivolumab, the overall response rates were not impressive at 33 and 17% in small numbers of patients with PTCL. However, the real winner for checkpoint inhibitors in T-cell lymphoma are the NK T-cell lymphomas. And this is data from our colleagues in Japan and the Far East, where they've extensively used checkpoint inhibitors in NK T-cell lymphoma and have seen some very impressive responses. In addition to seeing these clinical responses, there's been clearing of the infiltrate on serial biopsies. In addition, there's, as you can see, there's improvement and disappearance of the EBR positive cells. So this is a setting where you clearly could think about checkpoint inhibitors. However, in another disease, adult T-cell leukemia, checkpoint inhibitors have been associated with progression of tumor. And this is there have been a couple of articles published in the New England Journal and other journals as well, looking at small numbers of patients with ATL that receive checkpoint inhibitors. It turns out that PD-1 is a tumor suppressor gene in patients with HTLV-1 and perhaps other types of T-cell lymphoma as well. And so when you use a checkpoint inhibitor, an antibody that blocks PD-1, then you remove the suppressive effect of PD-1 and you can have acceleration of the disease. And so in the context of this disease anyway, checkpoint inhibitors should be used with caution unless you're in a clinical trial setting. Another disease where checkpoint inhibitors have been shown to be useful are cutaneous T-cell lymphoma patients. It turns out that both PD-1 and PD-L1 can be expressed on patients with mycosis fungoides and the Sézary syndrome. And more interestingly, PD-L1 can actually be translocated as shown on the right-hand side. We've seen a couple of cases where this has been described. And so there was a clinical trial that was done by the CITN, the Immune Tolerance Network in the United States, looking at CTCL patients with pembrolizumab. This trial was recently published. And you can see that the overall global response rate was 38%, with many of the patients having a complete or partial response. However, there were patients who had progressive disease, similar to what I showed you with ATLL. If you look at the progressive disease patients that I outlined in red here, 4 were Sézary and 2 were MF. Many of them were advanced stage disease. Many of them had multiple systemic therapies. In addition, we saw patients who had skin flare, and these patients were predominantly patients with Sézary syndrome. And the onset of skin flare did not correlate with response or progression, but skin flare was associated with the level of PD-1 expression in these patients. And also the cytokine IL-7 appeared to correlate with flare. Patients with higher IL-7 had a higher chance of skin flare. Another thing that we've seen again is aggressive progression of underlying disease. And this is one of my patients that really made me think twice about the use of checkpoint inhibitors off of a clinical trial. So this is a patient with CD8 positive aggressive T-cell lymphoma who received pembrolizumab, and initially on after the onset of this therapy, he actually had a flare. So he had perivascular infiltrate with mixed lymphocytes, but without evidence of his tumor cells, and that's shown on the top panel. However, 3 weeks later, he actually had worsening and exfoliation of his skin. And you can see that the new biopsies actually showed progression of his CD8 positive cytotoxic T-cell lymphoma with very aggressive skin manifestations. And so the point of this slide is that you can see inflammatory infiltrate and a skin reaction with pembro, but you can also see acceleration of the underlying disease. So again, I think use of checkpoint inhibitors really needs to be in the context of a clinical trial. I'm talking now just briefly about some microenvironment modulating therapies and how they might be implicated in T-cell lymphoma. So tipifarnib is actually a farnesyl transferase inhibitor that's been around for a long time, but it was found recently that it actually can target CXCL12, which is expressed in the microenvironment of many types of tumors, including aggressive T-cell lymphoma. And it turns out that in PTCL, the expression of CXCL12 in the microenvironment is associated with an adverse prognosis. And this is found in 50% of AITL and 35% of PTCL patients. And so tipifarnib actually downregulates CXCL12 expression in the microenvironment. And so there was a phase 2 study looking at tipifarnib in aggressive T-cell lymphoma with a response rate of about 40+%. That has not been published yet. And that study recently concluded. And this is one of my patients with PTCL with very aggressive stage 4 disease who failed CHOP therapy and went on to this clinical trial. He had multiple skin nodules, as you can see on the left. And after 2 cycles of tipifarnib, he had a complete clinical response. So this was very, very impressive. And I've seen this many times now, particularly in my patients with AITL. So I think this is going to emerge as a very effective therapy for patients with aggressive T-cell lymphoma that express a high level of CXCL12 in the microenvironment. Another thing about this drug is that it appears as though patients who have KIR3DL2 mutation have a higher chance of response. So those with the mutant KIR3DL2, as you can see, had a 75% response rate, whereas those with the wild type had a 25% response rate. So now we actually have biomarkers that will predict who's going to respond to this therapy. Another interesting drug is the myeloid checkpoint inhibitor CD47, which binds to SIRP alpha and provides a checkpoint against phagocytosis of cancer cells. This is an important pathway in patients with T-cell lymphoma. If you look on the right-hand side, you can see CD47 expression on different types of T-cell lymphoma, as well as T-cell lymphoma cell lines. And so these anti-CD47 antibodies now are in clinical trials in T-cell lymphoma and have shown efficacy. It turns out that the antibodies in an animal model system of T-cell lymphoma actually show activity to suppress the disease in various sites, such as the liver and the spleen, as shown here. And these animals had prolonged survival when they were treated with the anti-CD47. These slides are from Salvia Jain, who actually did these studies and presented this data. So now we're starting to think about CD47 as a therapy for these patients. And in addition, there's a concept to combine CD47 antagonists with checkpoint inhibitors as well. So I'll just briefly close with CAR T. So CAR T, of course, is of great interest in many different diseases. With respect to T-cell lymphoma, the antigens that could be targeted are varied, and there are various issues that could arise with CAR T therapy. So the CD30 CARs are in clinical trials for CD30 positive T-cell lymphomas and have shown activity in early studies. In addition, there's a CD5 CAR, and with the CD5 and the CD3 targets for CAR T-cell, fratricide is a significant issue, as well as long-term T-cell aplasia. So the CAR that I'm interested in that we have in clinical trials is a CRISPR-edited CAR that targets CD70. So CD70 is an important molecule physiologically in that it's expressed on activated lymphocytes, and its role is to control naive and memory T-cell activation via CD27. And it turns out that there's an elevated expression of CD7 on many different types of diseases, including T-cell lymphomas. And it possibly plays an immunosuppressive role due to T-cell exhaustion, apoptosis, or Treg expansion. So this has proved to be a reasonable target and an interesting target in T-cell lymphoma. So via a multiplex editing, a CAR has been produced, which is an allogeneic CAR directed against CD70. So to prevent graft versus host type reaction with this CAR, the T-cell receptor expression has been disrupted using CRISPR-Cas targeted to the TRAC locus. In addition, the CD70 gene is inserted into the TRAC locus. And to enhance persistence of these cells, the MHC1 expression is eliminated by disrupting the beta-2 microglobulin gene. And so that's produced this allogeneic CAR that's capable of targeting CD70 and also having persistence and not being subject to fratricide. So this CAR is now in clinical trials, just starting clinical trials in aggressive T-cell lymphoma, already showing some very promising activity. And this just shows you this particular CAR in a HUT78 T-cell lymphoma Sézary model showing very significant activity in tumor reduction. This is the clinical trial that's ongoing with lymphodepletion for 3 days, and then a washout for 48 hours, and then the CAR is infused. And thus far, we have not seen any significant T-cell aplasia associated with this, but it's early on in the course of this study. This is an immunotherapy platform for PTCL that's the subject of a global PTCL consortium, where we're combining a demethylating agent, azacitidine, with romidepsin, and then we're segueing in checkpoint inhibitors, in this case, durvalumab, and we're trying to look at different combinations of these agents to try to develop doublets and then triplets that potentially could be moved into frontline therapy, so that frontline therapy for patients with T-cell lymphoma would be fundamentally immunotherapy rather than chemotherapy. So that just in closing, I think there's a bright future for immunotherapy in T-cell lymphoma. We've seen novel antibody targets, and we're not yet seeing, but there are bispecific antibodies that are under construction that will be in clinical trials soon, as well as other antibody conjugates other than brentuximab vedotin that are now being developed. So I think those will be exciting. In addition, we've seen data for checkpoint inhibitors. We're now looking at combinations with other microenvironment modifying agents. And in particular, we are looking at combinations with mogamulizumab. There are various CAR Ts that are being developed, and I think CAR T therapy potentially in combination with other strategies would be very interesting. And again, our goal with all of this is to try to move immunotherapy further to the front line as a potential way of curing more patients. So with that, I'd like to close, and I'd like to thank you very much for asking me to speak at the forum, and I'll entertain any discussion questions. I just want to point out that there is an International T-cell Lymphoma Forum that we sponsor every year. This year, it's going to be a virtual event, and I would like to invite anybody in the audience interested in T-cell lymphoma to participate and/or to submit an abstract. Thank you very much for your attention.